I'll take over the speaker. Then before your presentation, I'll give you a short CV, biography. Then you can take over the mic, right?
Okay.
Sangha, are you there? Are you ready?
Yes, sir. We are live in YouTube now. So we have 3 minutes left before we broadcast this.
Okay. So Sangha, our presentation is somewhat changed. The first speaker will be Guido, then Dr. Mantu Gupta. Okay?
Okay.
I think.
Sanjay, Dr. Swain is asking, are
Yes.
you ready?
Yes.
So have you responded to him? He is not connected yet, no?
No. So I sent him message.
Okay.
I hope Professor Cheng will join us little later as he's traveling at the moment. So he will be joining little late. But I'm not seeing Will Finch. So we have 2 minutes more. Okay. I think Sven is on.
Latif bhai, namaste.
Namaste.
So, you are ready?
Oh yeah. It's just a quick introduction, and
then it is 6 p.m. For me, it is 6 p.m. Retired from the day's job.
3:15 here.
Yeah.
Isn't that? So where is Will Finch? I just sent him message to log in. Dr. Will Finch is operating. He will join us little later. So shall we start? Okay.
Okay.
Sangha. Sangha, are you there?
Doctor, shall we start now?
Yes, yes.
I will play a video, then we can start it formally, right?
Yeah, we can start.
Okay.
Because 2 people are joining little late.
Okay, sure. We are online now.
Yes, Abdul Latif.
Okay, I'll share my screen. Okay, so okay. Good evening, good afternoon. Today we have the pleasure of being hosted by Dr. Kharji from Nepal, and we have an esteemed colleagues presenting from around the globe for showing the versatility of mini PCNL. This is myself. I'm a consultant urologist in Kuwait. I work closely with Dr. Sanjay, and my interest is in minimal invasive and mini PCNL with flexible RIS and prostate surgery. Mini PCNL has came as a contender to the conventional PCNL, which was the gold standard to treat for large complex stones, but unfortunately at a higher cost with higher rate and severity of complications, mainly pain and bleeding. Mini PCNL came out as an effective, as a standard PCNL on several fronts with less blood loss and for the small and medium-sized stones. As we know, the stone burden is the key denominator for the optimal stone-free rate, but with time, it's been shown and proved that even in complex stone burdens is amenable for mini PCNL. Today, our host is Dr. Sanjay Kharji. He's a consultant urologist and medical director of Khargi Institute of Endourology in Nepal. He's been trained in endourology and mini PCNL in Guangzhou by Professor Zeng, who was a pioneer in mini PCNL. He introduced mini PCNL and prostate surgery to Nepal, and he's been hosted around the world for this technique. He's performed over 7,480 procedures and nearly 500 prostate surgeries performed by him by laser. He has been invited on multitude of events around the world, namely World Congress, Urology, Society of International Urology, Video Urology, Challenges of Endourology, and Expert in Stone Disease International, and he's a founding member of the International Alliance of Urolithiasis. Live surgery by him was done around the world in Europe and Asia and multiple times in India. He's affiliated with multiple professional institutes, and he's the pioneer, one of the pioneers in this technique. I present Dr. Sanjay to you, and with this esteemed panel. Thank you.
Thank you very much, Dr. Abdul Latif. Very good evening to our faculties, senior colleagues, and friends. On behalf of Khargi Institute of Endourology, I would like to thank our all faculties and participants. So I would like to thank Mr. Dipesh Pradhan, who is a general manager of Asian Pharmaceutical, who is sponsoring this event. And special thanks to Mr. Shanga Manandar, who is taking care of this IT, of this webinar, Versatility of Mini PCNL, the way I do it. Well, the incidence of urolithiasis is increasing worldwide, and the treatment of renal stone is one of the prominent branches of urology. It's one of the prominent. It is characterized by the innovation of new technologies and mini PCNL is one of the modality to treat the renal stones. Well, I did PubMed search. I found around 113 full articles on mini PCNL from 2013 to 2020. So it's evolving technique. Many people are adopting it in their regular practice. So today we have eminent surgeons from across the globe to share, as there is so much variation in this mini PCNL technique. So in this webinar, we will be covering the indication for mini PCNL technique, anesthetic issue, position of the patient, and different energy sources, and the outcome strategy. Well, today our first speaker will be Dr. Guido Gisti. I'll give him a short biography. Sorry. Where is it? Okay. Guido Gisti is a head of Stone Center and European Training Center in Endourology, Department of Urology, Ospedale San Raffaele, Milan. He graduated in medicine from the School of Medicine of University of Verona and entered residency of urology at School of Medicine of University of Verona, Italy. In June 1999, he moved to Department of Urology of Humanitas Research Hospital in Milan and became the head of the Stone Center from 2008 to 2015. He established the European Training Center of Endourology under the patronage of SIU and ULIS. Since 2012, he is associate editor of Video Urology, BMC Urology, and Minerva Urological Journal. He is a member of Society in Italian Urology, Society Italian Endourology, European Association of Urology, American Urological Association, and Endourological Society. He is author of more than 170 abstracts in national and international congress, 84 papers on indexed national and international journals. He is a reviewer of European Urology, Journal of Urology, British Journal of Urology, Journal of Endourology, and World Journal of Urology. He performed more than 30 live surgeries in the field of endourology in the most important national and international congress like WCE, SIU, and EAU. So I request Guido to present. I'll stop the share screen. Guido, you can share the screen, please.
Okay. Perfect. Can you see it?
Yes. Yes,
Yes.
Guido.
Okay, perfect. So thank you very much, first of all, to you, Sanjay, for this kind invitation, which is really important for me. And I also want to say hello to all my co-panelists, which are very, very important. So we will share our experience in order to benefit from this webinar. So first of all, it's important to underline this fact, because I can imagine that some of the listeners maybe are arguing, come on, Guido, you are the one that wrote this paper, so you are against mini-PERC. Well, this is an old paper that dates back to 2005. And honestly, I wrote this paper because I was one of the pioneers of mini-PERC. And it is true that from the very beginning, I realized that the blood loss was much less. But honestly, I realized also that the operative time was much longer. Pain was similar to standard PERC, but most importantly, stone-free rate was significantly less than standard PERC. Then also I read this paper from a young promising endourologist. Maybe you know him. The name is Professor Traxar. When he was fellow with Pearl in Dallas, he wrote this paper in which he was able to demonstrate that basically there was no real scientific evidence of real nephron sparing by decreasing the diameter of the access. So bad stone-free rate, no real stone nephron sparing. So I developed this feeling. So I had many complications, it was true, but also many results. That's why I wrote this paper. But look, the way I was doing mini PCNL at the time, there were no dedicated instruments at that time. I was using a semi-rigid ureteroscope, and basically, my most important fault was that I didn't understand at that time the vacuum cleaner effect. That is one of the most important points of mini-PERC. And we have to be grateful to Sven Lamen because he was the first to describe this effect. Then it was even more described in detail by Udo Nagele. And basically this vacuum cleaner effect is a combination of transportation and suction, which will extract for us all the fragments that we will have after lithotripsy. So since only the foolish and the dead alone never change their opinion, I did the same. I changed my mind, and the paper mini-PERC, yes, please, is on the way. So now I describe my personal technique. You know that I am one of the supporter of supine position. So also mini-PERC is always performed in supine position. This is the OR setup. You see that the OR is always very busy also because we have a very small OR, and it's important to have a schematic setup of the OR that should be all the time the same. You see that there are 3 surgeons in this animation. Usually I'm lucky enough to have a resident, to have fellows. So you know, we can be 2 or 3 of us, but usually you can do the same also in one surgeon. Ultrasound is always available in the OR, even though I don't do exactly an ultrasound puncture, but I always check the anatomy of the patient before performing my puncture. So which instrumentation should be available in the OR? Honestly, I'm more familiar with the MIP set from car stores. This does not mean that the other sets are not good, but of course I can tell you only about the one that I use. I like very much only MIPS and MIPM. MIPS is, let's say, similar to Ultra Mini-PERC, is 7.5 French in size, while MIPM is 12 French in size. And this is the complete set because the MIPS comes with 2 access sheets, and the MIPM, the one that I prefer, comes with 3 different sizes, which are 15, 16.5, and 21, as reported in this video. Positioning, this is the real advantage of supine position. It's very fast. This is you see how we arrange the operating table. We keep half of the table on the stone side and only 1 stirrup on the contralateral side. We rotate the patient only a little bit, provided that there is no retrorenal column. And we usually use this swimming noodle, which is more than enough to obtain this 10 to 15 degrees inclination. You see the position is very fast. This is real time in video. Huh? So only 2 nurses, 1 doctor is enough to place the patient in position. And these are our anatomical landmarks that we always prefer to draw on the patient's skin. So posterior axillary line, costal flange, and iliac crest. You see the swimming needle, the edge of the table, and remember that the patient should be a little bit inside because otherwise the kidney will lie over the metallic bar and your vision will be impaired. This is the final position ready for our mini-PERC. What is important is that we have a free access to the flank, but also free access from below to perform a simultaneous ureteroscopy when needed. So one of my points is that we still prefer to place an occlusion balloon in the beginning of the procedure because it's important to keep in mind that the more the kidney is dilated, the easier will be our punch. So usually we start with by placing this occlusion balloon. You see this case was a NIPS, a Y-like stone in in the lower calyx, we inject the contrast, we place the occlusion balloon. The system was already quite dilated. And usually we start with this puncture with the needle, you see, parallel to the floor. I would say that 90% of the time, with the needle parallel to the floor, we enter directly the targeted calyx, like in this video, you see. And most of the time we are in. Of course, if you miss the puncture, you have to do some triangulation to identify the correct depth of our punch. Now I was asked also to address the upper pole punch, because there are a lot of rumors around the world that one of the limits of supine position is that it is impossible to approach the upper calyx. Fake news. This is not true. It's more or less the same. Look at this case. This was a 2 centimeter stone in an upper calyx. You see, this kidney was very high. That's why I checked before performing my puncture with ultrasound that there was no liver in between, because you see that it was quite high upper calyx. So I don't do the puncture with ultrasound, but I check because there was liver in between. This is the stone. And now you see the technique is more or less the same. Is more or less the same, always under fluoroscopy. And you see, when you see the kidney moving under the action of my needle, most of the time it means that you are in correct position. I introduced the guide wire. I introduce I use most of the time only hydrophilic guide wire, then I dilate, and then mini perc is the same. Another variation of mini perc that I really like a lot is the one that I usually call stepwise approach. Look at this. I did a perfect puncture on the upper calyx because the stone was only in the upper calyx. Sometimes you are not able to make the guide wire going down in the ureter, which I really like a lot before dilating the tract. So I do stepwise. What does it mean? I start with MIPS, which is the small one, like ultra mini perc. So like in this case, I got access to the upper calyx with this 9.5 metallic sheet. I performed just a little bit of lithotripsy, then I gained access to the infundibulum. And once the guide wire was down in the ureter, I enlarged my tract to standard mini perc, which is 16.5. And only at this point, I started lithotripsy with more effective and bigger axer for mini perc. Again, another example of this concept of stepwise PCNL. When I have a very difficult cases like this, there was a liver because we were on the right side. I had some retrorenal column. I did my puncture under, I checked before with the ultrasound, but believe me, the window was very small. So I prefer to get a small access, 9.5, like I did in this case. And then I explore, before dilating with a bigger diameter, to explore the tract according to the concept that if you have an injury, a small injury is better than a big one. So like in this case, you say, I got access. And when I was inside, look, I explored the tract with the safety guide wire in place. I explore, no injury along the tract. So I decide to enlarge it to standard perc, 16.5. Well, we can skip this. When I miss the depth of the puncture, we have to do triangulation. So we move the C-arm toward the patient head. And of course, if our needle will move up, it means that we are too posterior. So we have to move the needle up, and so that we will identify the depth. Of course, if you are very good with ultrasound, unfortunately, I'm not so good, you can do the same by ultrasound. And I think that Mantu will show this to all of us. Tract dilation. Once I have the guide wire safely inside the system, usually I do only a single step dilation with a metallic dilators that is part of the storage set. And usually for mini PERC, this is, I would say, really safe and respectful for the renal parenchyma. For sure, even now in this case, I didn't make the guide wire going down in the ureter. I feel much safer when I have the guide wire in the ureter because you can push, I would say, more relaxed just because you are sure not to have inadvertent perforation of the collecting system. I use always a safety guide wire because, you know, even though you are an expert, we all know that one of the limits of endourology is that the limit from a masterpiece. A disaster sometimes is very small, so I prefer always to keep a safety guide wire. Well, once you are inside the kidney, of course, we can start our nephroscopy and we can start with our lithotripsy. For me, in my opinion, lithotripsy in mini PERC should be performed exclusively with laser. You can do also with shock pulse, with trilogy, but I think that the laser is much more effective. And usually I use fragmentation setting and non-pulverization setting. Not all the authors agree on this concept with me. Some prefer still to perform pulverization, but I really prefer to have a fragment so that I can remove all the fragment much faster, just taking advantage from vacuum cleaner effect. Now I want to address this topic. It is very important that this is an advantage of supine position. According to this paper that we wrote together with Mario Sofer from Israel, in supine position, due to the anatomy of the abdominal wall, is much easier to get the upper calyx through the lower pole axis when compared to prone, 80% versus only 20%. So most of the time, you can reach the upper pole and extract all the fragments. Sometimes it's not possible. And remember that you can introduce a flexible ureteroscope through your metallic ampla sheet and remove by basket, even though it is rarely necessary. And don't forget that you can also perform mini edges. That means simultaneous manipulation with the ureteroscope. This is sometimes is necessary, and this is the advantage of supine position. It's very easy to introduce a ureteroscope during the surgery and to look like in this case to a stone in a parallel calyx to retrieve and to pass the stone to the laser from the nephroscopy. It's important when you do mini edges to use disposable scope because sometimes, look at this, I fire by myself on my Flex 6C inadvertently. I call it friendly fire. So I prefer to use a Boston LithoView most of the time. And remember that if you bend also the ureteroscope on the metallic sheet is very sharp and you can damage your reusable scope. Exit strategy. At the end of a mini PERC, I prefer always to place a stent retrograde and not to leave any kind of nephrostomy. I leave the stent with the strings so that the patient can remove the stent by himself at home instead of going back to the hospital. Look at this. I check the placement of the stent in the kidney nephroscopically so that I spare some radiations. And I check the position of the stent only in the bladder by X-ray. Then Foley catheter overnight. I retrieve the nephroscope. I always check the tract at the end of the surgery, just to be sure, again, to confirm no injuries to adjacent organs, and that's it. So at the end, by readjusting my technique, actually, I'm very happy with the result that I have with my supine mini PCNL. And as you can see, my stone-free rate has increased again and is similar of the one of standard PERC. And in my hands, mini PERC is a wonderful weapon that we have in our hands and is ideal for medium-sized stone in the kidney and also for small-sized stone in unfavorable anatomy. I thank you very much for your attention. Thank you very much.
Guido, it was an excellent presentation.
Thank you,
thank you very much. So we'll take several question answers after the presentation, not now, at the end. So I'll move on to next speaker. We have a Guido.
Okay. Tell me, what's wrong?
It's okay.
Ah, okay.
You have to stop sharing. Okay. So next speaker is Dr. Mantu Gupta. He's the chairman of urology, Mount Sinai West and St. Luke's Hospital, director of Endo-Urology, Mount Sinai Health System, professor of urology, Icahn School of Medicine at Mount Sinai. He is recognized as one of the leading endoscopic percutaneous and minimally invasive surgeons in the world, having performed over 10,000 major endourological procedures. Dr. Gupta was given a Presidential Gold Medal by President Ronald Reagan for his academic achievements and has served as a visiting professor both within the United States and throughout the world. He has published extensively in major peer-reviewed journals and authored numerous book chapters. He did his urology residency at the top-ranked University of California at San Francisco and completed a fellowship in endourology at Long Island Jewish Medical Center under the tutelage of the founding father of endourology. Mantu, please.
Thank you, Sanjay, for that introduction. Can you see my screen?
Yes, we can see you.
Can you see my screen now?
Yes.
Okay. So I'm doing a semi-live procedure. So I'm going to show you a case that illustrates exactly how I like to do my mini PCNLs. This is a case of an 80-year-old Caucasian female presenting with sudden left flank pain after a recent fall. She states that 20 years ago, she had a history of a bowel perforation from a ureteroscopic stone procedure, very strange history requiring a bowel resection. She was deathly afraid of having another ureteroscopy. Review of systems revealed no particular findings. She did have some mild dementia and some urinary incontinence. History of anxiety, depression, hypertension, hepatitis, and hyperlipidemia. Prior bowel resection is mentioned. She's on those medications mentioned here. So we ordered a CT scan given her intermittent right flank pain, and there was a 2-centimeter obstructing stone at the left UPJ with mild hydronephrosis. The stone density was 1,083 Hounsfield units. There were also several calyceal stones, as you'll see. The track length, as we measured on the CT scan, was 7 centimeters. So the plan was, based on our findings here, to perform a left supine outpatient tubeless mini PCNL with ultrasound guided access, which is my typical approach for supine PCNL, for mini PCNL. So you can see here her CT scan. You can see that she had a number of smaller stones in various calyces. And some people think that may be a contraindication to mini PCNL, but I find that really we can get to these calyces quite nicely. This is the large stone. You can see it's causing some edema of the renal pelvis. There's a lot of thickening of the renal pelvis around the stone, not much space. And it's quite a large stone that's causing hydronephrosis. I'm pointing out here that the fat pad behind the kidney, we always look at the anatomy around the kidney. Luckily, there's no spleen in the way, no colon in the way. It's a relatively straightforward access from the supine PCNL. And I point out the supine PCNL, usually we're approaching more from this angle than from the posterior angle. This again is the coronal views, and you can see the large stone here and the calyceal stones as well. And you can see your anatomy is very favorable for a supine PCNL, which is coming from a little more lateral approach and anterior approach than the prone PCNL.
Welcome everyone. I just wanted to show you the position I use for.
So I'm going to turn off the sound here, but this is the position I use for supine mini PCNL. I put a gel pad on one of the leg, and like Guido, I'd like to keep this leg straight, and I like to keep the other contralateral leg a little bit bent. I mark out the posterior axillary line, the 11th and 12th ribs, and the iliac crest. We draw a line basically from the ASIS, which is the anterior superior iliac spine, to the posterior axillary line. And we like to keep our access on this line or more posterior to avoid any bowel injury. But I do all my access with ultrasound guidance, as I'll show you. So it's important to mark out the ribs. And sometimes there's a very small window here. Luckily, this patient had a relatively generous window of where we can do our access. But as Guido showed you, you can also go intercostal as necessary to go to the upper pole. Now, if we do our access into an anterior calyx, it tends to be along this line. And I find there's an advantage to the anterior calyx access for supine PCNL. And that's a little talked about, although some of the original studies described how you can go in anterior calyx versus a posterior calyx with supine approach. I'm showing the arms here that we pad them nicely and have them on top of each other. So there's no brachial plexus injury. And this is basic position. This is our instrument set that we use. Here you can see that this is a MIP set. This is the same set that Guido showed you from Stortz. This is the 16.5, 17.5 sheath that we typically use for access. And this is the Trilogy. I'm going to show you how we've been using the Trilogy. This is a 1.5 millimeter probe. And I'll show you how we use that. So this is we start our procedure by performing a cystoscopy. And we find the ureteral orifice, which is quite easy in the supine position compared to the prone position. Very easy to find that ureteral orifice. And this gives us good access if we ever want to do combined approach. Although we rarely do it, we have the ability to do it if we need to. So here we are finding the ureteral orifice. It's quite easy. The anatomy is relatively normal compared to prone. And we start by placing a guide wire up. And as Guido does, we also put an occlusion balloon. Here's our guide wire going up. Here. This is the retrograde pyelogram. As you can see, this lady actually had a ptotic kidney. The ureter goes like this and comes down and then goes back up. And the kidney is like a drooping lily. It's falling back down on itself. In this case, it was very nice that we were able to get a guide wire past the stone, as you'll see here. Here's our occlusion balloon going up. And we're able to get the guide wire to wrap into the renal pelvis. And what we're able to do in this case is blow up the occlusion balloon past the stone. And here's the occlusion balloon. One caveat with the occlusion balloon is try to never do more than 1.5 cc's or else you can rupture the balloon. Here's the balloon inflated and it's past the stone. And what we're able to do is straighten this kidney out just by pulling on the balloon and pulling the kidney down. And so we're taking it from a drooping lily position more to a regular position here. I do ultrasound guided access, so I don't actually like to put any contrast, although sometimes if I wanted to find the anatomy better, I do. I'll often put saline and then use my ultrasound to define the anatomy better. And here we use an ultrasound guide. It makes it very easy to do the access. Backtrack here a little bit. So you can see our kidney. We can see, I like to start with a longitudinal view so we can see the upper pole and the lower pole all at the same time. The stone is right here, and you can see the calyx, posterior lower pole calyx is nice and visible here with the saline and the collecting system. I use the guide. You can see the yellow dotted line here. That's the guide of where our needle is going to go in. And actually, this access was relatively straightforward. So we put our needle. The nice thing about the ultrasound, you can see, make sure there's no colon in the way, and there's our needle, and it went right in. It only took a couple seconds to do this access. And you can see the tip of the needle right there, the bright echo. We detach our probe. And you can see that we went into an anterior calyx era right on that posterior axillary line that we had drawn. This is the guide wire going in. And you can see the guide wire coiling in the renal pelvis. We now make our skin incision. As you can see here. And these patients, some of our patients are interested in cosmesis, most of them are not, but we try to make the incision as small as possible. Since we're doing a mini perk, one of the advantages is that it's a smaller incision. So I make it just large enough, then I use a clamp to expand the incision just to the right size. And like I prefer using the Storz MIP set, and I use a 16.5 metallic sheet. But we also use a clear Petra sheet sometimes, which is has a suction side port, and I'll show you what that looks like as well. We start our dilation with a 10 French fascial dilator. And I use, even though I use ultrasound guidance for the access, I always use fluoroscopy for the dilation. I think it is possible to do the entire procedure under ultrasound only, but I don't feel comfortable with that quite yet, and I don't really see the advantage of it in sparing a few seconds of radiation to be sure that we're doing the right thing. This is the clear Petra sheet. It's a single action dilation, single step dilation, and it's got a side port for suction. So you can suction the particles out. And the nice thing about that is you can bring the particles out to the side port without actually removing your scope from the entire sheet. So you can actually go in and out very quickly compared to a metal set where you have to come all the way out, let the pieces wash out, and then go back in. So it just saves a little bit of time with that. And there's also continuous suction during the procedure. So the smaller little dust particles are coming out as we're doing the procedure. So here we've done our dilation in a single step. There's a cap that goes on that goes over the wire, so you can keep your safety wire in place. And at the same time, with the cap, you have the ability to prevent outflow along here and have the outflow just come out through this side port. So the side port doesn't allow air to get suctioned in, since you have a rubber seal for your scope. And there's a suction being attached to the side port. So now we're introducing our nephroscope. Keeping our safety wire in place. And to see with this lower pole access, it was quite easy to see the occlusion balloon, as you can see there. And we withdraw the occlusion balloon till it's at the UPJ, so it'll prevent any stones from migrating down during our procedure, and I think that's very important. And there's the stone. It's a fairly large stone causing some edema in the renal pelvis and some inflammation. And here's our trilogy probe. It's a 1.5 centimeter probe. So this probe I usually use at a frequency of 8 hertz, 100% suction and 100% ultrasound energy. And you can see it very rapidly breaks the stone and suctions it at the same time. Some people say, well, can you get any fragments really out of 1.5 French probe? And actually it suctions very well. And it's got a collection bottle, so the pieces get collected toward the end. But the nice thing about having the clear Petra in this sheath is any smaller particles that don't get suctioned out with the ultrasound go through the sheath. You can see here very rapidly, we can break this stone up. I use the thulium laser and the holmium laser as well for mini PCNL, and I've used them both, but I prefer the Trilogy for harder stones. I think for the harder stone, the pneumatic or ballistic effect it has breaks those harder stones quicker than the laser does. And we have good control. You can see because we have suction, the fragments don't fly everywhere. Sometimes with the holmium, you get dispersion of fragments into other calyces. But really with the suctioning there, the pieces stay put right in front of you and don't migrate out. They don't tend to migrate out. See pretty quickly here, we are breaking the stone and suctioning out. I'll show you in a second here the vacuum cleaner effect as well, and how we can use the clear Petra sheath, the side port, to evacuate smaller fragments pretty fast. Our goal here, unlike the laser, is not to create small fragments, but to have good sized pieces that can still be suctioned out using vortex effect. So we're not trying to get it into fine particles. We're just trying to break it up, especially with a large stone. It's much faster to break it into big, good sized pieces that can be vortexed out. So here at the end, there's a few particles that didn't get removed through the ultrasound suction. And here we are just using the vortex effect to draw them through the clear Petra sheet. So here's we turn the fluid on with the pieces near the edge of the sheet. And the particles follow our scope and they come down the channel. They are dropped down the channel. We go back in. We bring them out through the channel again. And we can go in and out very fast. So it's a little bit faster than through the metallic sheet. And as Guido mentioned, it's relatively not that difficult to get to the upper pole in supine position compared to prone position. You can see we can take our mini nephroscope there and get into the upper pole. And we can also go down the UPJ easier. We're not afraid of damaging the UPJ because it's a smaller sheet. Final fragments here coming out. There's our occlusion balloon. We always want to check and make sure no fragments went down along the occlusion balloon. It's not foolproof. And you always want to push your balloon up and make sure there's nothing behind it. And we are withdrawing our sheath and making sure no fragments went behind us, because that's a common problem with these smaller sheets, mini sheets, is that fragments can get trapped behind you and the calyces behind you. And you always have to check that. And then we always do a final inspection with a flexible ureteroscope, as Guido mentioned as well, to make sure that we get all the little stones. And you can see that there were little stones in some of these other calyces that we saw on the CT scan. You can find these stones relatively easy with the ureteroscope, either from below, retrograde, or through the mini sheet, and basket them out or remove them or laser them out if you couldn't reach them with the rigid scope. Most of these patients, almost every mini PCNL case we're doing these days, here's the few pieces we found. Most of the mini perks we're doing these days go home the same day. And I like to send them home without a stent if possible. So many of the cases where we use a open-ended catheter, a 5 French open-ended catheter in the renal pelvis, attach that to the Foley catheter. And about 1 hour after the procedure, the Foley catheter and ureteral catheter come out. We have the patient void and they go home totally tubeless. If there's any question of edema at the UPJ, and I think this patient had the stone that was sort of impacted at the UPJ, if there's any question about edema that they may not drain, if you're worried about bleeding or any blood clots, of course, it's always safer in those situations to leave a double J stent. Here we are doing a thorough inspection. I make sure I get every calyx. I also check with fluoro and make sure there's no residual fragments with fluoroscopy. There's your ureteroscope inspecting everything. And then finally, we put the double J stent. That can be put in retrograde or antegrade. I prefer many times in a female doing a retrograde because you can easily dunk the stent back into the bladder that way. But in males, I prefer to do it antegrade because you can coil the wire in the bladder, antegrade, and then push the stent and make sure it's coiled in the bladder. It's harder to use the pusher. So here's the stent coiled here in the collecting system. And then finally, the last step is withdrawing the sheath. I withdraw the sheath and I inject some flow seal into the tract. Here's the flow seal going into the tract. With the metallic sheath, I do it through the sheath itself because it has an introducer. And this patient she wasn't bleeding really, she didn't need much. And you can see the final incision there is quite small, barely visible. So the patient satisfaction is very high with the mini PCNL. They're very happy when they come back that they were able to leave the same day and that they didn't have stay in the hospital and the incision is quite small. So I think that's the end of my presentation. Chance for questions and answers later on if anyone has any. Thank you.
Thank you very much, Dr. Mantu. It's a wonderful demonstration. So we have seen two different positions, different energy sources used in a mini PCNL technique. Now I would like to call upon Professor Sven Lame for his technique. I hope Sven is with us. Sven. Sven. So let me introduce you. Professor Sven is head of department, executive shareholder and medical director, Department of Urology, Gold Star Private Clinic, special urological clinic for minimally invasive surgery and robotic assisted Da Vinci surgery for Pforzheim, Germany. He was the vice head of Department of Urology, University of Tübingen. He was the head of Department of Urology, Center for Minimally Invasive Therapy, Robotic Assisted Surgery. He is currently executive shareholder and medical director of Gold Star Private Clinic. Professor Sven is a member of German Urological Association. He's a member of European American Urology Association. He's a member of also German Society of Reconstructive Surgery, member of International Society of Urolithiasis, International Alliance of Urolithiasis, German Society of Robotic Assisted Surgery in Urology. So his main interest is in endourology. He's one of inventor of mini PCNL in adults in 2001. He developed various disposables in endourology, occlusion catheter, ureteric catheters, ureteric access seat, tipless basket, special hand grips. He performed more than 250 endourological live surgery, more than 30 organizations of national and international workshops in endourology. Sven, you can share your screen. Sven, you have to unmute.
Sanjay, can you hear me?
Yes, yes, Sven. You can start, please.
Yes. Okay, Außenkamera bitte. Außenkamera. Just a moment, Sanjay. Wir brauchen jetzt die Außenkamera.
Professor Sven will be directly demonstrating from his theater. He has a unique position in mini PCNL and he has a special X-ray machine. It's something different from the fluoroscopy. So today he's going to share about his technique. Sven, please.
Jetzt du die Außenkamera. Fertig? Okay, I can. You can hear us and see us. Is everything okay?
Yeah, perfect.
Okay. It is an honor for us to participate in this webinar organized by you, by our Nepalese friend. And we would like to introduce you to the so-called original mini PCNL technique, which is now 20 years old. Mini PCNL is older than 20 years because we started mini PCNL in 1998. And in 1999, we designed a special mini nephroscope to perform mini PCNL in adults. We first like to show you the first publication dealing with mini PCNL in adults. Einmal die Publikation zeigen, das ist die zweite Folie, wenn es geht. Just 1 second, please. Geht nicht? Our presentation is a live presentation, which means we need a little more time to connect you to the particular slides. Jetzt die zweite Folie. Okay, this is the first publication dealing with mini PCNL in adults. And up to now, we did not change anything in doing mini PCNL, which means we are now doing mini PCNL for 20 years and we have changed nothing. And what I want to do is to show you directly from the operating theater how we are performing mini PCNL. Dann das Detail von unserem OP-Tisch. At first, I want to introduce you to the instruments. Okay. Einmal das Detail zeigen. This is a puncture needle we are using. Later on, I show you how we have a special ultrasound probe in order to perform an ultrasound guided puncture to the kidney. After we had punctured the kidney, we are using a very, very simple guide wire. This is a stainless steel guide wire, no hydrophilic coating, no flexible tip, a J-tip, of course, but this is only stainless steel, which is very, very cheap. And this particular guide wire facilitates the dilation. The dilation is done as a so-called single step dilation. We only have one dilator. The tip of the dilator is sharper than from the Storz equipment because Storz equipment had been introduced in 2008 and this one has a sharper tip. We invert this dilator and this dilator exactly fits to the stainless steel amplat sheath. Bisschen mehr Detail. Amplat sheath is put over the particular dilator. Ja, bisschen mehr aufzoomen. Just a moment. Okay, genug. This is a dilator and the amplat sheath exactly fits to the dilator. After the amplat sheath is introduced into the calyceal system, the dilator is taken out. And we are using the mini nephroscope. This nephroscope is from the Richard Wolf Company. It is the same nephroscope as in 1999. This is introduced through the amplat sheath. And if you have a close look at the tip, you can clearly see that there is a certain space between the mini nephroscope and the amplat sheath. I can move the nephroscope inside the amplat sheath. Mehr Detail. More. You can clearly see that there is a certain space. And this is the space where the small fragments which are produced after holmium laser lithotripsy can be removed only by irrigation flow. And this is, from my point of view, the main difference of conventional PCNL to mini PCNL. The so-called vacuum cleaner effect allows us not to use any forceps or graspers anymore. all stones are coming out through this very small space. This is all. This means that at the end of the MDAT over there, it is not allowed to close this. Okay? After the procedure, a nephrostomy tube is placed. We are using a 12 French silicone balloon nephrostomy tube in order to have the possibility to perform a second session mini PCNL if it is needed. Okay, these are the instruments. And now I want to show you the positioning of the patients. Übersicht. Okay, this is our operating theater. We have a patient. This is one of my scrub nurses. I don't hope that he's sleeping. Are you sleeping, Dominic? No. Okay, we're removing this because it's very cold. We have a special X-ray table. This is a fixed X-ray table. These are the X-ray coming from there, going down. This is a digital version of X-ray, and this is completely different to a C-arm. We don't use any C-arms since more than 20 years because radiation exposure using a C-arm is very high, and it's always a lot of work to have a good positioning of the patient. This X-ray machine coming from the Siemens company allows us to have a really clear X-ray image, and we can show you an example of a large renal pelvic stone. Bitte mal Röntgenbild zeigen. Herr Anudo, lassen Sie es. Ja? Nee, wir wollen es ja auf dem Sendemonitor haben, ne? So, kann gesendet werden. Okay, now you can see the X-ray and you can see the balloon catheter who is inserted above the uteral pelvic junction. This is a special balloon catheter. You can clearly see a metal ring. We don't use any contrast dye to inflate the balloon as we saw from our American colleague, because if you apply any contrast dye through the urethral catheter in order to inflate the balloon, there's a high risk that the balloon sticks and you are unable to deflate the balloon. Therefore, we decided to put a special metal ring inside the urethral catheter and to have a clear vision on the position of the balloon catheter. The case that is shown on the X-ray is a good indication for mini PCNL. Dann wieder Übersicht zeigen und mir den Ultraschallkopf geben. Now I'm going to show you how we are performing the puncture. The first step, what we are doing is we are taking our needle and putting it on the skin of the patient. And the idea is to put the tip of the needle, mehr Detail. Mehr Detail. Nein, nicht so viel, Herr Golsch. So. The idea is to put the needle on the skin and to put the tip of the needle in the target area, which means normally the lower pole. In order to facilitate the puncture, the patient is lying on a special cushion. We can show the cushion. Ja, Nudo, mal etwas hochgehen, dass wir es noch ein bisschen hochschieben. This is an inflatable cushion, which means we can adjust the cushion to the particular shape of the patient's body. Okay, können wir mal aufpumpen. Weiter, weiter, weiter. Noch ein Stückchen. You can clearly see that we can adjust the inflatable cushion. This leads to a movement of the kidney. There's a certain tension of the kidney to the skin, and it makes it easier to do the puncture. If we want to change the position of the patient during the procedure, no problem. We can deflate the cushion. Etwas ablassen. Now we are deflating the cushion. Yeah, geht schneller. And the cushion is becoming smaller. Okay, good. dann Ultraschall. Once more, the first step is to put the needle on the skin, and the tip of the needle should be in our target area. And then I know the best angle how to put the needle. But in order to solve this three-dimensional problem, we are using ultrasound to do the puncture. This is our ultrasound probe. Bitte mal Detail. This is a special ultrasound probe. And you can see, mehr Detail, viel mehr Detail. In die Mitte vom Bild. Noch mehr rein und in die Mitte vom Bild. Reinzoomen. Okay, nee, so, okay. You can see that this is an ultrasound probe where the needle comes through the ultrasound probe. And this provides us a very, very clear vision. The needle is taken through this hole. And you can clearly see that it is coming out. Bitte hier zeigen. Höher. Höher. Okay, näher ran an die Spitze. Näher ran. In die Mitte, Herr Kolsch. In die Mitte, Herr Kolsch. Good. You can see that the needle is coming through the ultrasound probe. This is really the best ultrasound probe to do a percutaneous puncture. Okay, now we can have a look at the ultrasound image. Bisschen gel. Übersicht. Ultraschallbild einblenden, bitte. In our operating theater, we have the X-ray image on our left and the ultrasound image on our right. And now we are transmitting the ultrasound image. There's the puncture line. And of course, at the moment, I don't do any puncture because our scrub nurse is not suffering from any stone. What is the advantage of doing an ultrasound guided puncture? The advantage is that we can clearly see if there is any interposition of a bowel. CT scan is also nice to have, but we don't need any CT scan because we need an exact imaging of the particular position of the patient during the procedure. We don't need an imaging of the patient lying in a CT scan. This is really completely different. And sometimes bowel is moving and we can clearly see where the kidney is, where the lung is, and where the bowel is. From our point of view, it is really obligatory to perform ultrasound. And this can only be done by the urologist because we are able to perform the percutaneous procedure. The radiologist has no experience to do any surgical procedure. We are doing an ultrasound guided puncture, but after we had inserted the guide wire, the single stent dilation is done under fluoroscopy because it is better to have a clear imaging of the calyceal system after applying contrast dye. Once more, ultrasound guided puncture and dilation under fluoroscopy. Dann wieder Übersicht zeigen. Mehr Detail. Hier nochmal auf das Detail zeigen. Okay. Now, if we have inserted the amplat sheath, it is very important to have an open end of the amplat sheath. You can see this later on if we show our short video. Today, we already saw that there was someone working with an ultrasound probe and suction. Mini PCNL does not need any suction. Or in other words, suction in mini PCNL is not recommended because fragments are coming automatically out of the amplat sheath. If you are using suction, probably the calyceal system is collapsing and you have not so good vision. Therefore, in our opinion, it is better to use only laser lithotripsy. And laser lithotripsy not only means holmium laser, but also the new thulium laser with new possibilities for stone disintegration. After we have washed out all the small fragments, we are inserting the same guide wire once more. We are removing the amplat sheath and inserting a nephrostomy tube. Of course, this procedure can also be done as a tubeless procedure, no problem, whatever you like. Okay, now we want to show you a video, Übersicht. Dann können Sie das Video noch einschalten, was wir besprochen haben. Now we want to show you a video, something like a semi-live surgery, where the main step of percutaneous stone surgery is explained, and this is the puncture procedure. Just 1 second, please. It's gesendet? Okay. You can clearly see this is the target area. And this is a place where we do our puncture. The first step is to apply a mixture of methylene blue and contrast dye through the balloon catheter. This leads to a certain dilation of the calyceal system. At first, we put the puncture needle on the skin, and the tip of the needle should be in the target area. You can see this clearly on the X-ray screen. Now we exactly know from a two-dimensional perspective where to hit the lower calyx, but we don't know how deep the kidney is. And the depth of the kidney is determined by means of ultrasound. You can see the ultrasound probe. This is put exactly on the line from the needle. And now we are puncturing the kidney by means of ultrasound guidance. This is also one of the special ultrasound probes for percutaneous puncture. A small incision by means of the scalpel is done. And the needle is inserted. Up to now, approximately 3,000 mini PCNL procedures had been done. And up to now, there is no severe complication, no bowel injury, no liver injury, nothing like that. If you are successful, there is a urine coming out of the puncture cannula with blue color. The stainless steel guide wire is inserted through the needle. This is done under fluoroscopic control. If the guide wire is in place, the needle is taken out and the single step dilator is used. It is advisable to turn the dilator around, not only to push forward, because this facilitates the access to the kidney. After the single step dilator is in place, we use the amplat sheath. This is a special reusable amplat sheath. This sheath is approximately, I think, 15 years old now. I'm not sure. And this can be pushed forward also with turning movements under fluoroscopic control. In experienced hands, the access to the kidney sometimes only lasts a few minutes. This is faster than positioning to do shockwave lithotripsy. The single dilator is taken out. And the mini nephroscope is used to have a look at the stone. And always remove the so-called security guide wire. Mini PCNL cannot be done with a guide wire because we always need the space between the nephroscope and the amplat sheath. Außenkamera. Okay. Okay, what I want to show you is that for mini PCNL, you only need 3 items. That's all. If I do live surgery in foreign countries, I only take these 3 parts. That's all. Because needle is always available, guide wire is always available. You always need these 3 items. And these are reusable. This is one of the main differences to flexible ureteroscopy. And if you follow to all these small details, the success of mini PCNL is really, really high. Okay. We have finished our presentation from Pforzheim, and probably later on, there may be some questions. I don't know, Sanjay, I think discussion is planned at the end of the presentations.
That's true. We'll take the all question answers at the end of the session.
Okay.
Sven, thank you very much for demonstrating patient's position. And you have a unique X-ray machine that you use for mini PCNL technique. Now,
yes,
I thank you very much for the demonstration. Now, I request Dr. Paul for the next speaker. Let me introduce him. Sven, you can stop sharing your screen, please.
Yes, please. Das heißt, wir müssen irgendwo was ausschalten, ne?
Okay, let me introduce Dr. S.K. Paul. He's a senior consultant urologist, Apollo Hospital, Holy Family Hospital, National Heart Institute of New Delhi, India.
Yeah.
He developed a special interest in urolithiasis in 19, sorry. Just a moment. Okay, I don't see that letter 86. He's devoted his career on stone disease. He completed 10,000 PCNL operations in July 2018 and has organized 8 large international live operative workshops on PCNL every even year at New Delhi, India, called Perkins. Last Perkins 2018 was attended by 840 delegates. He participated as live operating faculty for demonstration of various types of PCNL surgeries in 182 live operative workshops all over the globe, including at China, Turkey, Doha, Iraq, Pakistan, Philippines, and Nepal. He has been invited to deliver talks on various aspects of PCNL in international meetings of Society of International Urology, European Association of Urology, World Congress of Endourology, Challenges in Endourology, Experts in Stone Disease, and during annual meetings of Chinese Urological Association, East Asian Society of Endourology, Pakistan Association of Urologists, etc. He is the Vice President of International Alliance of Urolithiasis, President of Golden Bridge Urological Association. Paul, sir, please.
Sure. Am I audible and visible?
Yes.
Okay.
Yes, sir.
So at the outset, I must extend my sincere thanks to Dr. Sanjay Khadgi to have organized this webinar and for making me a part of it just before inauguration of his own Khadgi Institute of Endourology. I extend greetings of the day to ladies and gentlemen amongst audience. By now, all of us have realized the versatility of PCNL which we are going to speak. Almost everyone has his own technique, but the results are the same. And to avoid repetition and boring you and confusing you with my technique, I will be covering some other aspects of PCNL in my presentation now. So coming to mini PCNL, the way I do it, I started PCNL in 1986, but since the turn of century, since the year 2000, as Swin has pointed out, the term mini perk, which implies to the use of track size less than 22 French size, it has become increasingly in fashion. Everybody wants to talk about it. But as far as my bad reputation goes, still my 40% of the patients are dealt with standard PCNL, because the patients which I get with stones of more than 4 to 7 centimeter size, I feel such stones are better tackled with a 24 French Amplard sheath and a 19 French nephroscope. Some stones, about 10% of my stone bulk, is so huge and so many tracks and such hard stone which will require a 30 French track with the 26 French nephroscope. So this is the 40% bulk which I still do standard PCNL, and I find it difficult to manage with miniaturized set. I agree. 50% of my patients, though they require this particular type of set, minimally invasive PCNL, MIP. 15 French sheath is being used for such cases where there is a localized stone in the inferior calyx. I use 18.5 French sheath when there are multiple stones and I need to do work a little more extra. And I will be using either a 21 French metal sheath or a 22 French sheath to manage such stone, which is on your screen now, which is a heterogeneous stone, which everybody can know that it is going to fragment into small pieces and will come out very easily, even with the 22 French sheath. Still, 8% of my patients, they need a miniaturized set of 14 French Amplard sheath with 12 French nephroscope, which I will call not ultra mini, but yes, still mini PCNL, because I respect the infundibuli. So I depend on my stone bulk and the anatomy of the pelvic calyceal system to choose the best particular instrument set. In this case, when there is a long thin infundibulum and entry to this stone can only be through these calyces, through these infundibuli, I'll be using a 14 French Amplard sheath and a 12 French nephroscope. Some stones are very difficult stone. They are not amenable to RIRS also because they are in a, and I don't want to go on spoiling my instruments. I am purchasing my own instruments. So for such stones, sometimes I'll be using a ultra mini PCNL directly through the Elkin cannula. I will pass a 8 French nephroscope, and with the holmium laser, I will dust or fragment the stone. And because there is no possibility of passing a forceps through this small nephroscope, I will just dust it and leave it there, like we do in RIRS. So this is the spectrum of my PCNL, and I fully appreciate that I have been given a chance to speak in this because 50% of my patients are still mini PCNL. So I will not be covering the technique. Technique is very simple. All of us have got and developed according to the availability of our instruments and our experiences. I will be speaking in this the way I do it only on these two technique, on the two parts. One is the choice of my anesthesia, and secondly, my technique of initial puncture. At the end, I will give few comments about controversy between prone versus supine. Anesthesia of my choice is spinal. It will surprise to many people, but just listen to me for a while. Patient is alert and communicative all the time. This is one very big advantage. He participates while turning prone and takes care of his neck, arms, and shoulder himself. He positions his neck according to his convenience, which he likes the best. In between, he changes also his neck position from right to left. So he is very comfortable when he is in spinal anesthesia. We don't have to worry about that as we have to worry in GA. As we have experienced through this episode of COVID-19, we know oxygen saturation is still its best when the patient is in prone position. The best part is early identification of complications. Why the PCNL or mini PCNL has gone to disrepute? Because the proponents of RIRS, they claim that it is a very complicated and a procedure which is going to give a lot of morbidity. If you are able to identify the complications early, like if there is going to be hypotension, even before you see on the monitor, the patient will start telling you he has feeling of nausea and vomiting. His tachycardia guides you how much bleeding has taken place. If we are by mistake filling his chest with this saline, then he will have breathlessness. He will let you know he is having some breathing problem. If we are not very careful and we push on going fluid in his abdomen and there is an intraperitoneal intravasation, he will start telling of discomfort in the abdomen and he will start vomiting. So you can easily identify the complications as soon as they start when the patient is under spinal anesthesia, as compared to when he is under general anesthesia. You will know all these complications only at the end. Then post-operative analgesic requirement is very minimal, because when he comes out, his limbs and everything, lower limbs are just numb, and he comes out smiling. On this stretcher, he is playing with his stone, which we have given to him. And that is a good tool to show that he has comfort. He comes out like he is coming out of an adventurous sport. He tells that he has the stone out now with him. He is not restless as shouting. As a person, when he is coming out of general anesthesia, I know, all of us know that most of these patients, they will go on complaining that they want to pass urine. They may not have pain at the site of the PCNL, but they will tell that they need to pass urine. All these things are not there when we are dealing with this spinal anesthesia. And lastly, listen to me carefully. It helps you tremendously in supracostal punctures when you are doing the case under spinal anesthesia. Why so? See, all of us know the kidneys will go down, and we want the kidneys to be down so that the injury to the lung parenchyma can be avoided. When we are doing a supracostal punctures, the kidneys should go down, and kidneys will go down only when there is a deep inspiration, not in expiration. When the diaphragm goes down, the chest expands and the kidneys, they will go down. So for deep inspiration, now we also know that the pleura has got a parietal pleura and visceral pleura. Visceral pleura is attached to the chest wall and parietal pleura is attached to the lung parenchyma. We want to create enough space between these two to gain entry through the transpleural transdiaphragmatic approach to the kidney. So we want to have some space between these two when the kidneys are going down. When we ask our anesthetist colleague to descend the kidney down and the patient is under general anesthesia, he pumps in air. And once the air is pumped in, the lungs, they expand. And once the lungs expand, the space between parietal pleura and the visceral pleura narrows down, and the chances of injury to the lung is more. While when we ask the patient who is under spinal anesthesia to expand his chest, he uses his respiratory muscles. He is expanding his chest. Little bit he inhales the air also, and the pleural space opens up. We have a good space for making the puncture. So a good space gets created between the parietal and visceral pleura only when the patient is under spinal anesthesia and not under general anesthesia. We give general anesthesia only those cases where there are children, when there is a young unmarried females, or when there is a very long complex stone which is going to take long time. So these are my comments with spinal anesthesia, and we have discussed at length, Sanjay Khadgi and myself, Both of us are really fond of spinal anesthesia. I am sure he is going to endorse my views. Now coming to the second point which I want to discuss today is puncturing techniques. We know there are three types of different puncturing techniques: bullseye technique, triangulation technique, and gradual descent into the kidney. This was the name coined by me way back in 1990, and now I realize many people have started using this term, and they have started using this technique. In bullseye technique, we only bring the patient, bring the CM either at 0 degree or 30 degree. And then we see the target calyx. We put the needle on the skin at the target calyx. We bring the needle tip, needle hub, everything in the same straight line, and then go deep, 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 either in 0 degree or in 30 degree. We go deep, deep, deep till we hit the target. It's very simple technique. Anybody can learn it. Anybody can do it. It is called bull's eye technique. And this is being utilized most often. And this also utilized by me also when there is a great difficulty and I am not able to succeed in any other way. But the disadvantage of bullseye technique is you have started the puncture at this area, gone deep, 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 and you will be puncturing this portion of the renal parenchyma and take an entry inside. When you take the entry of this at this area, this is the area where below the cortex there is a arcuate arteries. Or if you go even little more medial, there is interlobar arteries and the bleeding complications are more. Not only that, because you are making a puncture like this at about 80 to 90 degree angle from the skin and you are entering inside, the initial part of your track is vertical. Our track should be a straight track, not an angulated track. And your vertical part of the track comes from the skin up to this target which you have made. And now once you have made the target and if the stone is here, what you will do? You will be tilting your this implant sheath and you will come like this. When you are tilting and coming forward, there is possibility that you will tear the parenchyma and there will be more bleeding. So these are the disadvantages which I see in bullseye technique. Way back in 1901, this was shown to us that there is a white line, Brodel's white line, he had shown by anatomical dissection that this is the area with the minimal amount of bleeding and anatrophic nephrolithotomy was being done through this area. We have all done it in the past. This is the area from where we want to gain entry with the gradual descent technique. In gradual descent technique, we always position the siam at 30-degree tilt. If I was going to do a bullseye puncture, I would have started the puncture from here and gone deeper, deeper, deeper in this. I will not start the puncture from here. I will position the siam. I will see the target, but I will position the needle entry point at this level. When I position the the puncture needle here, this is what you see. The needle is seen at a distance heading towards the calyx and the infundibulum. Then I will gradually descend into the body like an aeroplane lands onto the runway. And it should hit the target. And this is the way when I go in, I will have a nice plane alignment. Straight, I will go into the infundibulum to the renal pelvis up to the PUJ. It will be the straight alignment to go in and the minimal bleeding complications will be there. This is the way which I suggest. We should make the puncture. We should touch this. We should enter the calyx. And from here, if we make the entry into the kidney, there will be minimum amount of bleeding or no blood loss. That is the reason in my 10,000 cases so far, touch wood, I have never had a case of angioembolization so far. And that is the way when we are making a puncture at the gradual descent technique, we are entering at the convex border of the kidney and not through the medial aspect of the kidney, which is going to be more vascular. If this is a right side, in right side, all of us know there are Brodel type of kidneys, and in right side, the posterior calyces are lateral and they are approaching towards the more periphery. So I always recommend we should puncture the most peripheral calyx in right side where there are more chances of having a broadal kidney. We should puncture the posterior calyx, and in the left side, because there are more Hodgson type of kidneys, it is the anterior calyx which is extending laterally and coming towards the renal parenchyma, towards the periphery, towards the convex border. We should puncture the anterior calyx on the left side on Hodgson kidney. But it is not fixed rule. There are many variations. The Hodgson kidneys can be on the right side, and the Broadal's kidney can be on the right side. So all this is possible. But my plea is initial puncture, whether it is a mini PCNL or is a standard PCNL, is the key, the main part of any PCNL. We should be very careful about that. We should make a short, straight track, because all our instruments are rigid instrument. They go straight line. When they go in the straight line, we should orient our track in the same way so that we can straight reach up to the stone. Most of the stones are in the pelvis. Lastly, few comments about prone versus supine. Again, here the technique comes in. If you are follower of a bullseye technique and you want to enter the kidney at 90-degree angle, it is always better to have a prone patient, because you have a very vast area from where you can make the puncture and enter different calyces. So you may require this area. But if you are doing a gradual descent technique where all your punctures are in this area from the posterior axillary line, only about 3 to 4 centimeter behind, if this is the area from where you are going to make puncture, it doesn't make any difference whether the patient is like this or like this. You have to use this area. So it doesn't make any difference. In supine position, this is the restricted area from where you can gain entry. You cannot go posterior and you cannot get entry from there. That is the only restriction. If you are a follower of a bullseye technique, in the beginning, you will find difficulty in turning from prone to supine. But if you are a follower of a gradual descent technique like I am, I don't find any difference whether the patient is lying supine or he is lying prone. I am to gain entry from this area, and then I can get and I can work inside. So that is my comment on prone versus supine. But yes, one thing we should keep in mind when you are studying, because both the techniques in the literature have shown absolutely similar results, absolutely similar complication rates, absolutely similar extraction rates. So there is no difference whatever you choose, but certain limitations are there, because whenever you know that when there is a superior calycial entry, superior calyx has two parts. It is not oriented anterior and posterior. Superior calyx are always oriented lateral and medial. If you are going to do only supine PCNL, you will be taking access through this area only. If this is the puncture, you will be puncturing this area and you will not be puncturing this area if you are following a supine PCNL. There will be situations like this when there is a huge staghorn. If you puncture in supine and you come from here, and then when you are extracting all the stone at 90-degree angle coming in, all these stones cannot be taken out with the supine PCNL. So in these situations, the prone PCNL will come handy. Straight you can come from inside, go deep inside, and you can have a 30-degree here and there. And most of the stones, except the most lateral ones, can be taken out from this track. So this is how, even if the supine PCNL is there, I will be using if there is a big staghorn, I will be using this particular technique and making a gradual descent technique into the center of the superior calyx, so that I have access to all the portions of the pelvic calycial system and get my stone completely out. Second part is when there are stones in the unascended kidney, like in this situation. Now, if you do a supine PCNL and start puncturing from here, see, this is the stone in the renal pelvis, and this is the calyx which you are going to puncture. This is the calyx inviting you to do the PCNL. So if you have to puncture this calyx in the supine position, it becomes very difficult. The whole length of needle will get consumed. Only then you will be able to puncture. So in this case, you will have to start from here, just at the center of the back, near the back. So again, you will have to turn the patient prone. This same situation, if this stone is there and you have to make entry, this is the calyx which God has given you to make a PCNL. Getting entry into this in the supine position will be difficult, but prone will be much easier. So don't have a fixed idea that I will be doing only this particular type of PCNL, only this set of instruments. Since I have all the 4 nephroscopes, 8 French, 12 French, 19 French, and 26 French, and all sorts of employed sheets are available. Since I am fond of spinal PCNL, but as well as in certain situation, I give general anesthesia. I can do in supine and prone. We should be really versatile and we should be exercising the best option for the patient. It should be a short straight track, minimum duration of the surgery, minimum complications, and maximum success. That should be the motto. So this is what was my today's talk about spinal anesthesia. My preference, my technique of initial puncture is always gradual descent technique, and I feel no difference between prone and supine. This is my conclusion. Thank you very much for a very patient listening.
Congratulations, sir. Very nice presentation. Every time we learn some tips and tricks from you. We all know that you are one of the master and finest PCNL expert in the world. We salute you. And I'm very happy, Pal sir, that I have been barking for mini PCNL from 2006 through a conference, Perkan. It took me 15 years to come up with mini PCNL technique. Thank you very much, Dr. Pal sir, for your excellent talk. So now I call upon Professor Cheng. He is my teacher. I learned mini PCNL from Professor Cheng, and we brought this technique to Nepal in 2005. So Professor Cheng visited somewhere around 20 times to Nepal in 2005 and 6. He is the head of department in the first affiliated hospital of Guangzhou Medical University. His interest is in urolithiasis working group of Chinese Urological Association, vice chairman, the International Alliance of Urolithiasis, chairman and secretary general, European Association of Urology section of Urolithiasis, board member, Endo-Urological Society Fellowship Committee board member, Research and Calculus Kinetics Society, BJU International and Urolithiasis. He is the editorial board member. He performed more than 20,000 mini PCNL surgeries, and he is the inventor of super mini PCNL technique. So I visited his center. They perform somewhere around 15 to 20 mini PCNL in one day. They have 7 operating rooms, exclusively mini PCNL technique with the use of ureteroscope. Professor Cheng, I hand over to you for your presentation.
Okay, hello. Dr. Sanjay, can you hear me?
Yes.
Okay, good. Okay. You can see my slides?
We can see you.
Okay. Okay. Dear friends, dear colleague, first, many thanks to Dr. Sanjay to invite me to attend this webinar on mini PCNL techniques. Next, we will talk about mini PCNL with suction, how I can do. as everybody learn,
Dr.
compared
Sinha, you have to share your screen.
now it's okay?
Okay, perfect.
Okay. Actually, compared flexible and shockwave, PCN procedures has a high stone free and high complications, sometimes bleeding and infection, even urosepsis. So, how to decrease bleeding following PCNL? Everybody must pay attention to 4 key points, 4 precise punctures. You make puncture from papilla, level from infundibulum. If we make a puncture from infundibulum, maybe cause too much bleeding. The secondly, carefully dilation. The thirdly, fewer exercises. Sometimes you can combine the flexible ureteroscope. Sometimes you can use flexible refluxoscope, but you maybe meet some very special situation. For example, this infundibulum is really low. Flexible refluxoscope cannot exist, not very difficult. And then you can avoidance talking the kidney. You do PCN procedures, you must gently. Okay. The last, you can use really small size PCN procedures. So too many mini-poke techniques come out. And how to decrease infection following PCN procedures? 3 key points are as follows. The first, effective treatment of pre-operative infection. You must do it. And then you must maintain lower pelvic pressure, no pressure. You can cause less fever, less infection, even urosepsis. And then you must shorten operative time. Actually, for mini PCNL, it's a good technique, but sometimes this technique can bring some problems. For example, the first is increased the stone extraction, even more than 4 centimeters. Maybe 2 centimeters is okay, no problem. But it's more than 4 centimeters little stones, because you always use pressure punch, flush the stone fragments. This is possible agrees. So maybe take a long time. Then you always use pressure pump. Maybe sometimes you can cause high pressure. How to deal with these all problems? Actually, in 2012, our team developed the super mini PCN SMP. What is SMP system? This is with 18 French refluxoscope with French 12 or 14 double layer suction exercises. This is really important. This is real innovation. For SMP technique, irrigation is from sheath, level from skull. And then you stone fragments, you are evacuated by suction. You not by basket, you not by pressure pump, flush stone fragments. But SMP has a limitation. For it's only suitable for stone size less than 3 centimeters. If more than 3 centimeters, because only 14 French axis may take a long time. Sometimes meet more than 3 centimeters, I can use a larger technique. It's French 18 one layer suction sheath with 11 French refluxoscope. Sometimes you can, this reflectoscope is not available, you can use simulate your reflectoscope. This technique I named enhanced SMP. Simply is ESMP. You see, this is ESMP instrument. This with suction, this exercise is 18 French, and this reflectoscope is 11 French, and the working channel is 6 French. So irrigation is enough. And this above picture is SMP, it's 18 French reflectoscope, and the suction shears is 14 French, and in the below picture is ESMP. ESMP is 18 French suction shears. There's some difference between SMP and the ESM technique. You see, SMP reflectoscope is 80 French, and the ESMP is 11 French, and the shears SMP is 12 and 14 irrigation suction shears. This is 2 layer shears, and for ESMP, and the shears is 18 French, and for irrigation, SMP is irrigation from shears, and the ESMP is from reflectoscope. And for lithotrips, and SMP is unlimited laser machine, and the ESMP, you can use laser machine, you can use pneumatic machine. And for indication, stone disease less than 3 centimeters for SMP technique, and more than 3 centimeters stone, little stone for ESMP. You see, this is 80.5 centimeters is a solitary cavity. You see, is Stegenham. And the ESMP with 80 French suction shears. And I use home laser machine for this case. Is L is 2 joules, and the frequency is 14 hertz. It's a very short time. From puncture to plaque reflectoscope tube is only 16-18 minutes altogether. You see, this is post-operative KUB. No stone left. Stone is free. And this is a larger case. I performed this case yesterday. And this case is boy, 14 years old, and the bilateral multiple little stones. This case had a primary hypoxyluria. I use ESMP in right side and 6 axes. You see, I can show this video to everybody. This patient is prone position, and I make puncture and the ultrasound guidance. You see, this you can ultrasound imaging. You can see different, too many stone echo, and then I make from this middle calyx, and I like use puncture guiding. Of course, you can make puncture freehand. Freehand is okay, but I like this. You see, this is, I get it, I think. And then I must check tactile is okay or not. And X-ray, in case of X-ray, I can see with middle calyx. I think a middle calyx you can go in upper pole, you can lower pole, you can go in pelvis, you can upper ureter. And I inject a contrast, but you see this is a very special system. Infundibulum is very, very narrow. I inject contrast, and contrast cannot pass the opening of calyx, cannot go into the pelvis, go into the upper ureter. I put a guide wire is outside. Because this low base no room for guide wire. And I often make one short dilation is 18 French metal sheaths. You see, and then I check position, dilation position is okay. And then usually I don't need a safety guide wire. And I check, I can see stone. And then I remove safety guide wire. No need guide wire. It's similar to Professor Swinami. I see, and then I connect this handle. This handle is is a part. This part connect suction. In this part, I have a venting. This venting you can open, close, and adjust the elective pressure. And for this technique, I can use pneumatic litho chips. Not always, you see, this is pneumatic. And then I suction this stone in the sheath and break it and suction out. Actually, I never use basket, forceps remove the stone fragment. Always suction stone. This is very fast, you see, very fast. And this is multiple stone. Actually, I try to use my scope pass this infundibulum to the pelvis, but this infundibulum is very narrow. It's only past the guide wire. Maybe you go in, maybe you talk this infundibulum close, too much bleeding. You see, I do 1, 2, 3, 4. This is 5 puncture. I have another upper calyx stone. I do 6. 1, 2, 3, 4, 4. This is 4. This is 5. 6 puncture. I always make a puncture be ultrasound guidance, and then I see this. This is stone's impacted stone. This calyx is really less. And I think the last small particle, I cannot make a puncture. Maybe second session. Okay, you see it's 1, 2, 6 punctures, 6 axes. I put 4 tubers, okay? Actually, my colleague compare ESMP and conversion as mini PCNL for these little stones, and this is RCT. This clinical trial was published with World Journal of Urology. You see, for patients for patients' data before operation is low difference because this stone size, stone hardness, and the stone score, and it's the same, not different. But you see the lithotripsy time, ESMP is short than the conventional mini PCNL, and the stone level efficiency is higher in ESMP group, and the operation time is short in the ESMP group. And then you see its pressure is lower in ESMP group. So that's the conclusion. ESMP has a multiple function suction sheaths, which can keep it lower in the lower renal pelvic pressure and higher stone remove efficiency when compared to conventional mini PCNL. ESMP has a safe and efficient in the treatment of more than 3 centimeters little stone. Lastly, ESMP is a cost-effective procedure because no need a basket, no need a forceps to remove stone fragments. And then the usable metallic suction sheets, maybe you can use more than 100 times. Is okay. So this is cost-effective procedures. Okay. Thanks your attention. Sanjay?
Moment, please.
Okay, I finished. Thank you, sir.
Nice presentation, Professor Cheng. Thank you very much for joining us today. So we have seen the different variations of mini PCNL. Now I call upon Dr. William Finch for his presentation.
Good afternoon, Sanjay.
Mr. Will Finch is a consultant urological surgeon. He graduated from Guy's and St. Thomas Hospitals in London in 2002, having been awarded a first-class degree in physiology in 1998. He completed his specialist training rotation in the East of England region. Most of his training has been in tertiary referral teaching hospital, Cambridge and the Norfolk and Norwich, including a year of a chief resident, and he has undertaken a short stone surgery fellowship in Kathmandu, Nepal. He has been a consultant urological surgeon since 2014. He is an honorary lecturer at the University of East Anglia. He is the audit lead for the endourology section of BAUS. His main urology interests are the diagnosis, treatment, and prevention of urinary stone disease, whole beam laser enucleation of prostate, and minimally invasive BPH procedures, laparoscopic upper urinary tract urology, and diagnostic urology. Now I call upon William Finch for his presentation. Please, Will.
So thank you very much, Sanjay. I hope everyone can hear me. If someone can just give me a thumbs up, make sure they can hear me. Lovely, thank you very much. Well, thank you, Sanjay. It's a great honor to join you and the rest of the panelists. There's nearly 100 people watching this, and it was a trip to Nepal to come and see Sanjay, where I had my eyes opened to mini PCNL, and I learned a lot from my 2 weeks with Sanjay in Kathmandu, and took several of his practices back to the UK, and here is what we're doing in the UK with mini PCNL. So if I have my next slide, please. So I think about doing mini PCNL in a number of different patients. First of all, it's stone factors and stones of above about 15 millimeters, but also hard stones with a density of over 1,000 Hounsfield units. There's certain anatomical considerations I think about, so the lower pole, specific calyceal and anatomical variations, and also patients with multiple stones. There's also patient factors which draw me to mini PCNL, those patients with bleeding risk, and also patients who want optimal stone-free rate, patients who want one procedure to get them stone-free. I have a pediatric stone practice, and mini PCNL works very nicely for those pediatric patients. And then for patients with who require antegrade flexible ureteroscopy, mini PCNL access is very useful for that. So next slide, please. So this is the case that this presentation is based around. This is a lady with a stone in her right kidney, which on the CT scan here is sitting in the upper pole, but she also has stones in the lower pole and a further stone at the PUJ. So next slide, please. So if we just go back one, please. So how do I do mini PCNL? Well, I do it supine. I use ultrasound for access with fluoroscopy guidance to aid my puncture. I only have one mini PCNL set, and that's the Storz MIP-M with a 16.5 French sheath. I use the laser to fragment, and I have a 100-watt holmium laser. And then my approach is to leave a JJ ureteric stent as post-operative drainage. So next slide, please. We've heard a lot about setup and positioning, and I've seen some nice techniques which I might try here today. But my standard approach is to use 2 1-litre saline bags, one under the bottom of the patient, one under the buttock, and one under the chest. But for the larger patient, as in the top right of the screen here, I will use a 3-litre saline bag, and that works very nicely just to elevate the loin of the patient to allow us to gain access supine. The one thing I would say, it's really important about positioning on the table, and you want the patient on the edge of the table, but not so on the edge of the table that you see the metallic of the edge of the table. So the positioning is really important. Next slide, please. So once I've got the patient positioned, I just check with my fluoroscopy, but then have a look with ultrasound and begin to plan my puncture and to check, as we've heard from other panelists, to make sure that what you're seeing on the day is the same as your preoperative imaging. Next slide, please. What's really important is having a standard setup, and I think that's the one thing that all of us on the panel here today do. It's really important to have the same team, and I've got a fantastic team in Norwich who are very supportive. I have the same instruments, the same needle, the same approach. I use ultrasound, and I also use laser. So a standard setup. Next slide, please. I use an ultrasound guided puncture, and I do that for a number of different reasons, because primarily it's the safest way to get to the kidney, and I think we all would agree with that. Next slide, please. What ultrasound allows you to do is see what's around the kidney. And on here we can see the kidney, we can see the liver at the upper pole, we can see the colon sitting just below the kidney, and I can visualize where my needle will get to if I'm trying to access the lower pole of the kidney, as with this case, and I can see it safely passing through muscle, fascial layers, and avoiding key structures. Next slide, please. I can also see the stone and get a real idea of where the stones are, and with this case, the upper pole component of this stone have actually moved to the renal pelvis. Next slide, please. And we can see quite clearly here the posterior acoustic shadow with that upper pole stone now sitting in the renal pelvis, along with 2 smaller stones, as well as a lower pole stone. Next slide, please. So I said I use ultrasound, and I use a freehand ultrasound technique. I think if you have people who are starting on ultrasound guided access, if you have the ability to have one of the jigs or one of the cutout ultrasound probes, I think they make life much easier and should be recommended. My technique and top tips for those doing ultrasound guided punctures is to have a good look and make sure you see the kidney and get an optimal image of the kidney. And then lift the probe away if you're making a lower pole puncture, as we are in this case. Lift the probe away from the skin to just to puncture the skin to allow you to get your needle in at the lower edge of your probe. It's really important with the freehand technique to introduce your needle, if at all possible, in the plane of the probe, because then you'll be able to watch your needle into the screen, on your screen, into the kidney, as we've seen from other presentations earlier. with the freehand technique, it's really important that you keep either the probe or the needle still at one time. If you move the needle and the probe at the same time, it can become very confusing. So get your optimal image of the kidney and try and make sure you keep your needle and move your needle so it's in your view. Next slide, please. I like to see once I've got the needle onto the edge of the kidney with my ultrasound, I do use a little bit of fluoroscopy, and I find it very reassuring just to see the kidney moving on the cortex, and as the needle's advanced, seeing the calyx just deflect and move as your needle goes in for the puncture. Next slide, please. Once you've made your puncture, using your ultrasound and fluoroscopy guidance, it's very reassuring to see urine coming out through your tract there. Next slide, please. So as part of dilatation, I do a stepwise dilatation. I use a 610 French dual lumen dilator, and I do place a second wire ideally down the ureter. I then dilate up on one wire and place a sheath, which is the 16 French metallic MIP-M sheath, into the collecting system, as can be seen on the image on the right there. For patients who've previously had a nephrostomy, if we're using the nephrostomy tract and dilating that, they can be quite difficult to dilate, and you may need to use a knife to incise any fascia or the previous nephrostomy tract. Next slide, please. So once we're into the kidney, this is should be a video running on the left-hand side of this case here, a little bit of blood clot as we place the sheath into the kidney, and we can see one of the stones sitting in the renal pelvis there. It's straight away, you can see it's a hard stone. It looks like a calcium oxalate monohydrate stone. The laser fiber I use is a 365 micron laser fiber. I'm lucky to have a 100-watt laser, and that gives me great flexibility with laser settings. But in a hard stone like this, I'd be starting at 1 joule 30 hertz, which allows me to fragment the stone nice and quickly. And I'm aiming for 4 to 5 millimeter fragments, which I'll be able to evacuate down my 16.5 French sheath. I mentioned I use 2 wires. I take my wire out from inside the sheath and leave my safety wire outside the sheath. And I find I think a safety wire is very important, especially when you have trainees with you, as it is an important get out of jail card. The one thing I really learned early on with mini PCNL is mobility of your sheath and being able to move the sheath around the collecting system to be able to pin fragments and use the pressure differences between the collecting system and your tract to allow stone fragments to move down. And it's, next slide please, and it's that vortex washout effect coupled with a supine tract which is angled down and below the horizontal. Next slide please. So the vortex washout effect is really important with the MIP-M system. It's all based on a pressure difference between the end of the scope, with essentially an area of vacuum at the end of the scope, and that relative area of higher pressure within the collecting system. And you can see that fragments about 4 or 5 millimeters in this case, they wash down the scope by withdrawing it slowly, very quickly and very efficiently. And here we can see the fragments wash out into my hand and then just into a kidney dish on the side there. But very quickly you can evacuate quite a lot of stone. And so part of the sort of efficiency with MIP-M mini PCNL is fragmenting the stone into those 4 or 5 millimeter size fragments, so that you can then clear stuff out. The other top tips is always having a clear idea of where your fragments are going. And with a lower pole puncture, they hopefully should wash down into the lower pole. And so, as we've heard already, it's very important to check around your sheath and behind your sheath to make sure you don't miss any fragments. But depending on your access for other cases, they may migrate towards the renal pelvis and the PUJ or the upper pole. And so it's very important to make sure that you're happy at the end of the procedure that all other calyces are stone free. And so I have a low threshold for using a flexible ureteroscope to have a look around the kidney at the end of the procedure. Next slide, please. So my exit strategy, I like to try and use a stent rather than a nephrostomy if possible. In the UK, we increasingly use stent on string, and that means that I can remove quite efficiently and quickly the stent about a week after the procedure, and my nursing team can help me do that. If there's any concerns, I will leave a 15 French nephrostomy tube overnight as an alternative strategy. And my patients tend to have a one-night stay as a routine. And so they have a catheter just overnight after the procedure, which is removed the next morning, and they go home with their stent on string. Next slide, please. So I mentioned, so if you could just click the image on the left, that should hopefully run as a video. I also mentioned antegrade flexible ureteroscopy. Here's a picture of me last week with COVID. In the UK, we've had difficulty with access to theatres for stone procedures, and unfortunately, we've had to deal recently with some encrusted stents, and this is a patient I had to operate on last week using a mini tract to get into the kidney and then pass a flexible ureteroscope down the ureter to laser fragment encrustations in a stent that had got stuck in the upper ureter. So it just demonstrates how mini PCNL is also adaptable to other aspects of endourology that we all use. Next slide, please. So if I could have my next slide. So my final slide. So my conclusions, I'm relatively new compared with the rest of the panel here to mini PCNL. I have been a practicing consultant for 6-7 years. But the key for me really is the fact that with a 16.5 French tract, we're stretching renal parenchyma, not tearing it. And that's borne out and demonstrated by the low bleeding rates and low transfusion rates with the procedure. When people are taught and understand the vortex vacuum effect, you can get very efficient stone clearance by aiming for 4 to 5 millimeter fragments for the 16.5 French tract, and what the fragments wash out very efficiently. Patients like it as there's less bleeding, less pain, and a quicker recovery and return to work. I think it encourages a nephrostomy-free exit strategy, and I think that's very important and has lessons to be learned with larger tracts such as 24 or 30 French tracts, which we may use for other stones. And so as a final thank you is having had my eyes open to mini PCNL by Sanjay and others around the world, it's become a very, very important tool for me as a stone surgeon, and one that works well for my patients here in the UK. And there's an increasing number of us in the UK using it. So I look forward to learning more and doing more in years to come. So thank you very much.
Congratulations, Will. Nice presentation and demonstration. I'm proud of you. You are doing good cases in UK as a mini PCNL. Now, I request all the participants to ask the questions to the faculties of this event. Let me share my presentation, how we perform mini PCNL in Nepal. Okay, so we have been doing mini PCNL for last 15 years. It's our regular practice. This is the instrument we use for mini PCNL. However, I learned mini PCNL from Professor Zheng with the use of ureteroscope. But nowadays, I prefer to use this 12 French mini nephroscope, 2 dilators, starting with the 10 French and 18 French. And I prefer to use Zebra guide wire. And we use pneumatic lithoclass of 1.4 mm. This is my table, operating table. We use the same telescope for the ureteric catheterization. And on top of that, we use irrigation pump. We hardly use the baskets. This is the irrigation pump. We basically remove this disintegrated stone by means of irrigation with the intermittent removal of the scope from the sheet, and at the same time, retrograde saline push by the assistant. So many people have concept that prone position is time consuming. In my personal view, it all depends upon your setup and your teamwork. We perform mini PCNL under spinal anesthesia, except in children, as Paul sir does. So this is an unedited video, as Paul sir already mentioned, that patient can take care of his shoulder, cervical spine, and the eye. It hardly takes 50 seconds to 1 minute. So there are several papers. There are several papers. They mention that supine prone position takes a lot of time when positioning. So this is our regular setup. This is our team. We perform under spinal anesthesia in prone position. So our puncture is supracostal, about 80% of the cases going through the middle calyx. As you can see here, whenever possible, I prefer to go through the middle calyx. Because when you go through the middle calyx, it will be more lateral. In mini PCNL technique, we try to achieve the angle of the sheet less than 60 degrees with the sagittal plane. If you go to the lower calyx or upper calyx, you cannot achieve that angle. And after making an initial puncture, we make a puncture on monoplanar most of the time. Once the puncture is done, then we place a Zebra guide wire. And first dilatation is with the 10 or 12 French, gentle rotation in clockwise and anti-clockwise direction. That makes much easier to advance the 18 French sheet, dilator and sheet, as you can see here. So we do not use continuous fluoroscopy. We use once the dilator is closed by the calyx. As you can see here, this is done again in rotating fashion in clockwise and anti-clockwise direction. Our X-ray is intermittent, not the continuous. Once the inner end of the sheet is placed in the renal pelvis, we remove the dilator and we inspect the system. We use 12 French mini nephroscope. We place the sheet up to the renal pelvis or at the PUJ level. Once it is confirmed that we are in the system, then we remove the guide wire and we advance the sheet at the PUJ level. Then we cut the sheet so that the length of the sheet is short. That is very important in mini PCNL technique. When the shot is small or short, stone evacuation is much faster. As I already mentioned, we use simple pneumatic lithoclass. which is of 1.4 mm. This pneumatic lithoclass is locally made, which cost hardly $700 to $800 in Asian region. So this is a calcium monohydrate whose Huntsville unit is 1700. We fragment them into multiple pieces about 3 to 4 mm of size. We do not dust these stones. Once these stones are removed, we do not keep nephrostomy tube in our regular practice. For stone size about 2.5 to 3 centimeter, hardly takes 20 to 25 minutes in our regular practice. So I would like to highlight about the importance of the angle of the tract. If we go make a more middle puncture, the tract will be more vertical, and that is not favorable for the mini PCNL to evacuate the stone at the vertical tract. When we achieve a tract angle less than 60 degrees with the sagittal plane, as you can see here, these both are supracostal puncture. Tract will be more horizontal, and this will be a straight align with the upper ureter. And stone evacuation with this angle will be more easier and comfortable. So why we choose mid-calyx? So mid-calyx forms the shortest distance to the kidney. We use fluoroscopy. We advance the need close to the calyx, just up to the calyx. If you see the lower calyx, there is a bunch of calyx. When you choose the middle calyx, most of the time you get the isolated calyx. In such calyx, puncture is much easier and bleeding is much less. Why middle calyx? When we make a middle calyx puncture, as you can see here, even with the irrigation that forms a straight alignment, even the fragmented stone can be removed very easily. Next. As you can see here, after the stone disintegration, we just did a retrograde saline push. This flushes out very easily. So, as I already mentioned, our puncture is supracostal in about 80% of the cases. It is completely safe. That is our regular practice. If you see this landmark, pleura runs from the middle of the 12th rib and runs upward and laterally. So usually our puncture site is in between 12th and 11th at the lateral side. So when we go through the middle calyx, it forms a neutral position, and it can swing our telescope up in the superior calyx without any difficulty and down in the lower calyx. Not only that, when we go through the middle calyx, we can also advance this scope up to the level of L4, L5 level. Even for the upper ureteric stone, more than 1 centimeter, I prefer to do mini PCNL rather than ureteroscopy, because our people, they want single stage surgery with the complete stone clearance, immediate stone clearance. So this is our paper, Safety and Efficacy of a Single Middle Calyx Axis in Mini PCNL. So we do not prefer to go through the upper pole. The reason behind this is when you go through the upper pole, number one, it will be a more vertical tract, as I already mentioned. Number two, we can avoid this pleural puncture. Number three, as you can see here, there will be too much radiation exposure to your hand. That is the reason why we try to avoid vertical tract. So many people are concerned about the intrarenal pressure in mini PCNL technique. This is a very nice paper published by Professor Zheng. Why I prefer 18 French tract. If you see this 14 French, 16 and 18, if you make 18 French, it has a least pelvic pressure. So that is one reason. And another thing, the important is there should be a gap between the sheet this video with the use of irrigation pressure, we can have a good flow from the side of the sheet that keeps and that maintains the intrarenal pelvic pressure. So when we perform mini PCNL, it has a high, many people talk in terms of bleeding, but with the mini PCNL technique, it has a high maneuverability. It minimizes multiple tracts. If you see this case, severely angulated system advancing from lower calyx to upper pole without any difficulty. If there is, this is done completely on endo view. If there is any resistance, we do not advance the scope. This is how we can avoid the pleural complication. Next. So what is the beauty in mini PCNL technique? This is the case entering from lower calyx. If you can make a puncture through the fornix, that we can get endo view like this, we can advance and see in different calyceal system. Not only that, even in a mild hydronephrotic, we can advance this scope in the upper part of the ureter, which works as a flexible. So this is the beauty of mini PCNL. You can confirm, one can confirm on table stone clearance. Only for the documentation purpose, we do ultrasound or CT scan very next day. So our people want one single stage surgery with the complete clearance. So this is the beauty of mini PCNL, which has a less bleeding and which has a high maneuverability. Also, it decreases the multiple tracts. Next. So let me share you some of the pictures performed by mini PCNL. This is a case of 46 years female patient, complete staghorn with the multiple tracts. We perform mini PCNL through the upper pole with the lateral puncture, as you can see here. So whatever possible, we did with the ureter mini nephroscope, clear with the upper pole stone and also the lower pole. The remaining cases, remaining calyceal stones, we just do saline push technique. This is the tip advocated by Dr. S.K. Pal, and I learned this technique from Pal sir. Sorry. So this is the post-op picture. This is intraoperatively complete clearance. And next day we performed CT scan with the complete clearance of the stone. Next, this is a case of 26 years male patient who underwent pyelolithotomy some 2 months back, had a residual stone, multiple stone. We perform mini PCNL with the 2 tracts and 2 saline push technique with the complete clearance. Even the complex, many people have concept that mini is only for the smaller stone that is less than 2 centimeters. So it is all depend upon your expertise and the instrument that you select. Even the complex renal stone like this is a case of 18 years female patient, bilateral staghorn. We first performed on the right side and second on the left side with the complete clearance. This is a large 6 centimeter stone in horseshoe kidney, as you can see here. We made 4 tracts, first upper pole and 2 middle pole and lower pole tracts. And as I already mentioned that we do not keep nephrostomy tube unless there is a pyonephrosis. We do keep double J stain, and about 10 to 15% of cases are totally tubeless mini PCNL. So this is a challenging case. Right non-functioning kidney with the left multiple renal stone. This patient traveled a lot from remote areas to complete this stone in single stage. So we perform mini PCNL with the 5 tracts, as you can see here, 5 tracts. This is the case of post-pyelolithotomy, and we did a complete clear in one sitting, and patient was discharged very next day. So this is the technique we learned from Dr. S. K. Pal. Whenever there is a calicial stone, we just make a needle push technique, and we fragment the stone and remove by the irrigation. This is another one example to flush lower calicial stone. And we are really fond of doing this saline push technique, and it is completely safe if you do the puncture to the periphery of the calyx. So I conclude my talk that mini PCNL is cost-effective, safe, and promising treatment for the stone more than 1 centimeter, and even in complex renal stones in upper urinary tract system. Thank you very much. Yes, Abdul Latif. You have to unmute.
Thank you, everybody, for a great webinar. We have quite a few questions. First of all, we have a nice comment from Jane Delorset. He sent his regards to everybody, and he's very happy with this webinar and the outcome. I have a few questions from, I don't know whether Dr. Guido is with us or he's gone to the OR. I think this can be answered by people who do the supine PCNL. If the stone migrates to the pelvis or upper calyx, what's their choice? Do they put a flexible scope, or do they do another puncture? That's the question.
Is Guido there? Guido? I think he's not there.
If somebody else can answer the...
you can ask Sven.
Sven or Dr. Gupta.
Yes, I think the migration of stones in mini PCNL is a very rare finding. I already mentioned that it is recommended not to close the ampler sheath. That means that always the stone which we are treating is coming to the tip of the ampler sheath. I do not really remember a case where a stone was migrating in the upper calyx. I think our main aim should be that we avoid any migration. And there is no migration if you're working with a so-called vacuum cleaner effect. What do you think, Abdul?
I think one thing we are talking about, and Sanjay made it very clear, when you have a middle calyceal access, this gives you access to the whole kidney. You can move to any calyx you want, more or less. And if there's an isolated calyceal stone, you can do a saline push There's no harm if it's very difficult. You can always put a flexible scope in, but most of the time, the rigid scope, if you have a good access, it will allow you access to all the kidney, more or less.
Yes, if we are talking about the access through the middle calyx,
yes.
We should talk about the positioning of the cushions. A lot of years ago, I did not understand how it is possible to puncture the mid calyx and to reach all the other calyces. But after Sanjay visited my department, I saw this. He never talks about this, but I'm going to do this now because Sanjay is using two cushions. One next to the thorax and one next to the pelvis, which means if Sanjay is puncturing the mid calyx, the kidney is very mobile. I showed you only one cushion, and this cushion leads to a certain compression of the kidney. If we are using only one cushion, we cannot reach each calyx. This means if we perform a puncture of the mid calyx, we need two cushions. But if we perform a puncture of the lower calyx, it is better only to have one cushion. This is very important to mention.
Okay, Sven. Sven, are your anesthesiologists happy with your cushion under the stomach?
Oh, you know that anesthesiologists are never happy at all. Okay. You know this from Da Vinci surgery in the beginning of the Da Vinci era. No anesthesiologist was happy, but with the ongoing time, they get more experience. And I can tell you that the cushion in the middle of the abdomen does not lead to any serious problems. It's no problem at all.
Okay, thank you very much. So, I would like to ask one question to Dr. S.K. Pal, sir.
Okay.
Pal, sir is there?
Yeah, I am listening.
So there is a very hot debate on papillary and non-papillary puncture. What is your opinion regarding non-papillary puncture, sir?
If you read the 18 articles published by Sempeio from 90 to 98 and really see the anatomical details where the puncture should be, even to the extent that he has, because he was an anatomist, he used to take out the fresh cadaveric kidney, he will put it on the X-ray plate, inject the contrast, make the puncture and dissect off the whole parenchyma and study the relationship of vasculature with the pelvic calyceal system. Very clearly, all his article and his endocasts have shown that on both the sides of the infundibulum, posteriorly as well as anteriorly, there are great vessels. But at the same time, you see all of us do all sorts of manipulations and insults to the kidney, and kidney still survives. Kidney still survives in spite of our best efforts. Kidney doesn't get killed. So there is the reason all the techniques are successful. Everything is okay. But if you go with the anatomical principles strictly, it should be a papillary puncture directly into the calyx. From calyx onwards on infundibulum, always take it into granted that posteriorly or anteriorly there are vessels. If you tear the parenchyma, if you tear the infundibulum and want to go deep, you will find some vessel. Why do you want to take a chance? I think my answer is very clear.
Very clear. Thank you. Abdul Latif. Is Manu with us?
Abdul, I just want to make one more comment, if you allow me.
Please.
Regarding the, Sven has said that migration will never take place. But Sven, there are, all of us have suffered migration of the stones. And particularly Sanjay, when he is utilizing a pressure pump, you cannot prevent the stone if it is a dilated system, because water always flows through the path of least resistance, wherever there is a least resistance. So if there is a less resistance in the superior calyx, the calyces and all the stones will go there. Point number 2, whatever has gone from here to another place, that is the open passage, it will come back also. So always learn saline push technique. If any fragment has gone back to any calyx, which is very much possible, all of us have gone through this, it will come back. If you saline, if you puncture that particular calyx and then give a flush, as Sanjay has shown two beautiful videos, where when you push the stone, such a large stone also comes in front of his amplard sheath. So why not? All the fragments will come back. So learn saline push technique, and fragmentation and everything will come back to you. Thank you for giving me the time.
So thank you, sir. Is Mantu with us? No.
There's a question from Riyad Al Haifi. Any experience with pregnancy and PCNL for the panel?
No.
The question is whether there is really an indication to perform PCNL in pregnancy. I think the aim is to treat the stone at the appropriate time, not immediately. And from my point of view, there is no indication to perform a PCNL in pregnancy. You can insert a double J stent. If this is not possible, you can insert a nephrostomy tube. But from my point of view, there is no reason to accept any risk of percutaneous stone surgery in pregnancy.
Dr. Finch, you had a comment?
Yeah, I would agree with that. I haven't seen or been involved with any percutaneous surgery in pregnant women. I think for ureteric stones, I think a timed ureteroscopy in a pregnant lady is very reasonable to disobstruct them. But if they've got a large renal stone and they need disobstructing a nephrostomy and manage their pregnancy and manage the stone after they've delivered.
Thank you. There's a question from Abuja, Nigeria, for Dr. Kalaba. Any place for flexible scope with mini PCNL? I think this was answered among our panel. There's a retrograde and antegrade flexible scopes can be done to look for residual fragments. We've got a lot of comments saying, thank you everybody for a great webinar, and they're looking forward for some more. And they congratulating you, Sanjay, on your new institute.
Thank you, thank you.
Abdul, removing stone is not at the cost of one life.
Yes.
And it is never an emergency. So if there is a solitary kidney, if there is a pus in the kidney, just put a nephrostomy and let the whole pregnancy go through. There has never been in my 30 years career, 34 years career, there has never been a situation where I have to do an emergency PCNL at the cost of a human being. So no chance should be taken for pregnancy. You should always put a DJ or put a nephrostomy and tide over the crisis, wait for 4 or 5 months, do it later.
I've got a question. He's how low is below UPJ you can extract the stone in mini PCNL? I think I'll, Dr.
We can go up to L4 level.
Yeah, this is from Gautam Mishra. We've got a question from Juan Manuel Lopez from Spain saying, what can we do to improve PNL procedures, fusion images for access, lithotripsy energy? I think I'll leave that to the panel. Go ahead, Dr. Finch.
Yes, I have one question to Will. Will, you always make a puncture under ultrasound, or you combine with the fluoroscopy?
So now I do it combined with fluoroscopy. So I use ultrasound right the way down onto the cortex, and we'll try and use ultrasound all the way into the calyx. But I do like fluoroscopy to just see the calyx just bouncing with your needle, and then for dilatation and for placing wires, I use fluoroscopy. Although colleagues around the world do use a totally ultrasound dilatation, but I think a limited, careful use of fluoroscopy is a very safe approach, and especially for teaching as well.
So there is a question from Muhammad Abdullah. Are you need intervention radiology in some cases?
One recently in a spina bifida with very, very, very difficult access. So I had an interventional radiologist for moral support.
Okay, thank you.
I'm going to have to run away. So thank you very much.
Thank you very much.
So if we do not have many questions, I have small announcement. So we are organizing mini PCNL workshop next year by September last or October first week in Kathmandu, Nepal. We plan to perform 20 cases of mini PCNL by all experts from the globe. We are going to invite, and this is an invitation to all the participants and faculties for this. You can book for the block your date for that time to visit Kathmandu, Nepal. So if we have no more questions, then
just one last question, Sanjay.
Yeah.
Somebody is talking about obese patients, the length of scopes and the sheath length for obese patients in mini PCNL. We can direct this to, William wants to, go ahead.
So I don't think there's any limit on the size of the patient, because you just cut down through the fat, and then you can use your 17, 18 centimeter sheath as you would. So you just incise through the fat, you'll have a bigger incision, but then it allows you to get down and give you the maneuverability with your sheath. So there isn't a limit as far as I'm concerned. Be interesting to hear what others think.
Sven?
Yes, 6 years ago, we worked on this topic, and we developed the so-called perfect perk, which means we have a big armamentarium of different amplat sheath. And what we do is we adjust the length of the amplat sheath to the particular shape of the body of the patient. But the more obesity we have, the more difficult it is to use the so-called vacuum cleaner effect. We have a look at the CT scan. We are determining the distance between skin and stone, and then we decide what type of amplat sheath we are using. And all the different types of amplat sheaths are working with the same mini nephroscope. In summary, this means obesity is a little bit more difficult to perform mini PCNL, but it is possible, of course.
Pal, sir?
Even in the very high BMI cases, if you see the fat distribution on the body, it is more on the lateral side and on the anterior side. From posterior aspect, even a 150 kg man or even 170 kg man will not have a very great length difference. So in my experience, I have not seen, even with very obese patient, if you do a prone PCNL, and the length will be a little more, maybe 2 centimeter more than the normal, which our amplat sheath should take care of. I see a longer amplat sheath needed when there is a horseshoe kidney or when there is a unascended kidney, because the kidneys which are situated at L3, L4 level, if they are unascended, the distance between skin to the superior calyx is too long. For them, you need a longer amplat sheath. We should have, as Sven has said, we should have longer amplat sheath. We should complete our armamentarium. Everything should be with us. But I have seen a longer amplat sheath more useful for the unascended kidneys, horseshoe kidneys, rather than in obese patient. Obese patient, I put prone or maybe a little more tilt and go as more posterior as possible. And then the length does not matter. You will be able to reach.
I've got one last question, and we close this session with. We've got it from Dr. Abdullah Naimi.
A very good friend of ours.
Yeah. He said, elaborate on how horizontal they need to go in a supine PCNL to puncture the posterior calyx.
Is Will there?
I think we lost our Supan guys.
Yes.
We got the pro guys behind.
The reason is that the prone guys are more frequent, approximately 80%.
That's true.
We keep it to the end.
Abdullah, you can summarize regarding this webinar and we can back up.
Yeah, I think this is a great webinar. Thank you very much for your attendance. And I think we showed, this webinar has showed that there's a versatility in mini PCNL. It can be done by different techniques and different maneuvers, but the outcome is superb, and it's equivalent to the standard standard PCNL with less complications. And there's an evolving techniques coming to mini PCNL with different approaches. And I think this technique is hopefully in the future, this is going to be the standard of care, given the less morbidity, the great outcome, and the equivalence of the outcome with the standard PCNL. I think with this esteemed faculty, I think this needs to be established more, and we'll do more teaching and disseminate this technique to the world to show that this is as good as the standard PCNL, and this can be learned and disseminated around the world with less complication and less bleeding. And thank you very much again for inviting us all. And I think we will see you soon, hopefully in the meeting in the Kathmandu for the...
Thank you, Abdul Latif. So I'm very much thankful to Swain Lamy, all faculties, Swain Lamy, Abdul Latif, Dr. S.K. Pal sir, and Mantu Gudu for their valuable time for this webinar. Thanks to Dipesh Pradhan for sponsoring this event. And thank you very much to Mr. Shangam Anandar. He organized very well. So thank you all and goodbye.
Goodbye, everybody.
Bye-bye.
See you all soon in Nepal, sir.
Thank you. Goodbye, everyone.
Bye, good night.
Thank you.
Good night, everyone.
Thank you. Sangha? Yeah. Stop YouTube live. YouTube live. Stop.